Good morning, everyone. I hope everyone is hearing me. Okay. So, in our series of these lectures, one the anatomy and the vestibular and the physiology of the vestibular system, and then we went through the ENG and VNG. And in the third lecture, we are seeing about the vestibular evoked myogenic potentials. So, what do we call as? What do we mean by this VEMP? Any muscular potentials which is recorded from the whole body, anywhere in our body, because of a sound stimulus. We call this as vestibular evoked myogenic potentials. Why? Because when we say vestibular evoked, we mean that we are evoking, we are stimulating the vestibular end organ. So what are the vestibular end organs? It is saccule, it is utricle, and the other three semicircular canals. So if any of these five vestibular end organs get stimulated by the sound, acoustic signal, and if they are represented in a myogenic potential. Myogenic means muscle related potential. So if we give a sound and we record a potential from any of the muscle from the body, this is called as VEMPs. We have not seen any semicircular canal responding to the sound. We previously saw that the horizontal canal, the lateral canal is stimulated through the change in the temperature in the caloric test. But all the three semicircular canals are not stimulated by the sound. So only the otolith organs are stimulated by the sound. One is your saccule and then your utricle. Okay. So what happens here? When we present a stimulus, it goes and stimulates the saccule or the utricle. Then we get responses from the muscle. It's either an inhibitory response or it is an excitatory response. Okay, so what you're looking at is a different VEMPs. All these are called as VEMP. Based on which muscle we are recording from, we will name it accordingly. So it is written SCM. Okay, so this is the famous one which we already know. There's a CVEMP, cervical vestibular evoked myogenic potentials. And what are the other one which you're very familiar with is OVEMP, that is IVO, which is inferior oblique. So we record our ocular vestibular evoked myogenic potentials from the extraocular muscle, inferior oblique. What are the other VEMPs which we don't know is masseter, VEMP, and we have other VEMPs like SE. Okay, SE is like a muscle behind the neck. Okay, so all these are stimulated by the sounds, but the real application of any test is in the differential diagnosis. It has to help in the diagnosis, or it's to help in the differential diagnosis of a particular disorder. Then only we will consider this as clinically applicable and we start researching on that. And when we see the most checked and most researched are only two. One is your CVAMP and the other one is your OVAMP. You're looking at the diagram of the ear as well as you're looking at the orientation of the utricle and saccule. In the class of anatomy and physiology, we saw that the utricle is responsible for the linear motion in the horizontal plane. It may be front and back, or it may be sidewards, left and right. And responsible for the up and down motion. Otherwise, the hair cells and the otolith membrane, the otoconia, everything is similar. Okay, the only difference is their orientation. One will be in the horizontal plane, and the other one, saccule, will be in the vertical plane. Okay. When we go in lift, okay, we actually realize that it is taking off. The lift is going up. Imagine if it's a very long floor and we keep going. After some time, we really don't feel like the lift is moving. And at the end, when it's trying to stop, we are feeling that it is going to stop. How does it happen? All these otolith organ, the utricle and saccule, are programmed, or they generate stimulus or the responses in a way that they don't real exactly mention what happens like at a particular moment. Rather, they check for the change in the velocity, which is acceleration. Okay, when the lift is taking off, it is just going up, what happens? There is a change in the velocity. The lift is not moving in a constant rate. It was in zero and now it is starting. So the velocity was zero previously and now it has some value. So this is registered in the brain through through saccule if it's a lift. Okay. Then what happens? Then the lift is moving in a constant speed or velocity. So there is no change in the velocity. So the saccule is not giving any different responses, neither inhibitory nor excitatory. So it is maintaining its posture. Then at the end, the lift is reaching the destination at the top floor. Now previously we had a velocity value, and now because it is going to stop, so velocity something, some value to zero. So when there is a change in the velocity, we feel that, okay, the lift is going to stop. The same goes with the utricle. When we start with a car and then we start moving, okay, when we keep moving in a particular direction, in the same speed, when we close our eyes, not driving, when someone else is driving, and when we close our eyes without, if there is no vibration at all, that's very important. If you close your eyes, you will still feel that the car is moving because of the vibration of the engine, or the other cues which you're getting. If there is nothing, just like the lift is goes up and comes down, there is no vibration or the sound of the motor, we will not feel that the car is moving unless there is a reduction or the increase of speed. So that's how the utricle and saccule are sending responses. Okay, when you look at B, it shows about how the utricle and saccule are oriented in the place. These diagrams we have already seen on our classes, just a refresher. Okay, so this is saccule and this is vertically placed. Okay, and this is a utricle which is horizontally placed. Okay, so we will be going into the first one, cervical vestibular evoked myogenic potential. This cervical evoked myogenic potential has a reflex arc. This is kind of a reflex, which means it happens without your voluntary attention. You really don't need to command your sternocleidomastoid muscle to respond. It will happen automatically. Okay, so what do? We start giving a stimulus, and this stimulus will reach the saccule. Okay, when it reaches the saccule is connected with the inferior vestibular nerve. We know that the eighth nerve, vestibulocochlear nerve, has two divisions. One is for the vestibular and the other one is for the cochlear. In the vestibular, we have two divisions, superior and inferior. Among those, the posterior and the saccule is giving its output through the inferior vestibular nerve. Okay, so from the inferior vestibular nerve, it has to go to the nucleus, vestibular nucleus, and from there it is going to send signals to the spinal tract. Okay, so it will be called as MVST and LVST, your medial vestibulospinal tract and lateral vestibulospinal tract. As we said, when there is a movement, we need to stabilize and we need to maintain posture. For that, we need inputs from the leg. Oh, sorry, we need the uh, integration of leg muscles. So when we command the leg muscles to balance, and then only the leg muscles will balance it, because it needs some kind of an input to act. It doesn't know what to do. Should I contract or should I expand? So these inputs from the saccule is going to help the leg muscles to act accordingly. And the MVST, your medial vestibulospinal tract, sends this, the nerve impulse to the sternocleidomastoid muscles nucleus, the motor nucleus, okay, the accessory nucleus, and then it sends input to the sternocleidomastoid muscles. It gives a command that you have to contract. Okay, so the stimulation of the saccule leads to the contraction of the sternocleidomastoid muscle. Excuse me. So why do we call it as a sternocleidomastoid muscle? We have sternum, right? We have sternum, and then we have mastoid. Okay, when anything that contacts these two muscle is called a sternocleidomastoid muscle. Okay, so this is a pathway. So we are not concerned about the utricle for now. So we will see about the saccule. The saccule go and stimulate the vestibular nuclei here. This one is your point, like inferior vestibular nerve, and then it goes and stimulates the vestibular nuclei. Okay, and then it go to the spinal tract. This is your dissection of spinal cord. Okay, from here it is sending responses to both ipsilateral and contralateral. Okay, it is one is telling to contract. Okay, what are the placements when you are trying to record a CVEMP? What actually we are supposed to do? We are going to keep our inverting electrode or the reference electrode or the minus electrode in the tendon of the sternocleidomastoid muscle, which means tendon means the end of the muscle. Belly means the middle of the muscle. It is very thick. Okay. So when you look at your bicep, okay, when you look at your bicep, when you try to show your biceps, you have two ends in the with tendon, and then you have a belly, which is how you show the bodybuilders show those biceps. That is your belly. Belly will be always bigger. Okay. So in this, we are keeping on the sternum, in the center of your sternum, which is we keep the reference electrode there, and then we keep our non-inverting or active electrode or plus electrode on the belly of the sternocleidomastoid muscle. Or in this example, they have kept above the center, which means at the superior 1/4 is what they say. Okay, sorry, superior 1/3. They divide the muscle into three, and then they keep it in the superior part, close to the mastoid. And we, as usual, keep a ground on the forehead. And we are going to present an air conducted stimulus. Okay, I repeat the placement. We are going to keep the inverting electrode or reference electrode in the tendon of the SCM muscle. The tendon is in the sternum. So we are going to keep it on the sternum, and then we are going to keep it in the belly of the muscle, the active electrode. So the active electrode will either be kept in the belly of the muscle, or we divide the muscle into three and we keep in the superior 1/3 of the muscle. Either thing is fine. And then we keep the ground in the forehead. Okay. Once we have placed it, the next task is to maintain a particular tension in the muscle. Okay. If we don't keep the tension in the muscle, we are not going to record our CVEMP. So what we are looking at is your EMG monitor. So this is going to tell me about how strong I have given keeping the strength of the SCM muscle. It has to be within the green. Okay, the needle has to be, it should be balancing. It should be moving within the green, and it should not go into red one. So what happens if it is coming less than the green? The responses will be rejected. It will not be counted. And if it is going above that, it will also be rejected. So any responses that is recorded with an EMG level in the green area will be counted and averaged. Other things are actually removed. And this, we are going to control it. You are seeing two handles down, which is minimum and maximum. So we will decide. We here I've kept 30 and 70. So any responses below 30 microvolt will be rejected, and any responses from the 70 microvolt will be rejected. Okay. This is your parameters. The most important thing is the filter. Okay, so always we need to be worried about the filter. Here the filter is 30 to 2000 hertz, and the number of sweeps is going to be less because the responses is a muscle response. So obviously it is going to be a larger wave, and we don't want more number of sweeps to make this wave much visible. Okay, then the analysis window is 50 millisecond. Why? Because the peaks which you're going to record is P1 and N1. Okay, the P1 we are going to get it around 13 millisecond, which can be extended to 20, and we are going to get N1, the negative peak, in 20 to 30 millisecond. Okay, so it's not going to be above 30, but still we are keeping buffer of 20. So together we will have 50 millisecond time window. Then we are going to have sampling rate, which is again we don't have much control over. We don't really change this. And then we are going to stimulate the saccule with 500 hertz tone burst. We can stimulate it with chirps. We can stimulate it with clicks, and we can stimulate with noise as well. But the tuning of the saccule is towards the 500 hertz, which means when I record with all the stimulus, we are going to stimulate with tone burst of 500, 1000, 2, 4, and even 8, and with clicks, chirps, noise burst. I see that the responses for the 500 hertz tone burst is better when compared to the other stimulus. And that's why it is understood that the saccule is having a better tuning to 500 hertz. That means when you present a 500 hertz tone burst, we are going to get a better responses than any other stimulus. Okay. Also, we have rise fall time of 2 millisecond and plateau of 0 millisecond, which means there is no plateau. There is only rise and fall time of 2 millisecond, and the responses is going to be only 4 millisecond, and the stimulus is going to be only 4 millisecond. And again, the envelope is going to be black man. We actually don't change it by default. It is black man, and the intensity which we are going to present is going to be higher. Okay, we are going to present at 90 to 100 dB NHL. So it can be 90 or 95 or 100 if you are going to record only one stimulus, and if you are going to record the threshold, we are interested in finding threshold, then we will reduce the intensity and we record. Okay, and the stimulation rate, which means how many stimulus am I going to present in 1 second, and I'm going to record the response. So I will be presenting 5 stimulus and I will be recording 5 responses in 1 second. Okay, what is an envelope? Envelope is actually designing or giving the stimulus a shape. Okay, as I told you, this is about gating. Okay, we'll switch on my video to explain that. Can you see me? Okay, is everyone seeing me? Fine. So what happens here is we have a gating like this. Okay, so I can keep like this. There is a gating like this. Okay, so we are going to present the stimulus from here, and we are going stimulus inside. We are going to present a tone burst. Okay, so the tone burst, what happens? It will be closed always. When we are going to present a tone burst, it is going to open and close. Okay, so when we present, it is going to open and close. When it opens and close, it will give us a shape. Okay, so imagine I'm going to open and close. So it is going to be like this: open and close. So that is your envelope. You have your envelope like this. What happens with the click? We have the same gating for the click. The click will be abrupt opening and abrupt closing. So like this and this, very fast. Okay, When we say rise time and fall time, we are meaning how fast it closes. This is the full. Okay, this is the full, which means any stimulus that comes, it allows inside as the full as possible. There is no reduction. Okay, so this is your plateau. Okay, and when it closes, it is your fall time. When it opens, it is your rise time. When we say 2 milliseconds, which means from this point to this point, it takes 2 milliseconds to open. Okay, 2 milliseconds, and because there is no plateau, it opens and suddenly closes. There is no maintaining of this position. Okay, so when we have two cycle, which is 2 rise, 2 plateau, and 2 millisecond fall time, we will have 2 milliseconds to open, 2 millisecond plateau, maintaining of this, and closing it. Okay, so that would mean your 2-2-2 cycle. Is it clear? Okay. So when we do all these settings, we have prepped the patient, we have done with the settings, all those things, and then we start recording the responses. Before we get responses, there are few tips which we need to know. Okay, we actually are looking for two responses. One is your positive peak, one is your negative peak. Okay, which is P1 and N1. The P1 is approximately around 13 to 15 milliseconds most of the time, and the delay of this latency is very rare. And N1 will be around 18 to 20 milliseconds, extending till 25 milliseconds. So anything that comes at this is only VEMP. We will also see some kind of sine waves coinciding with it, which will look like response, but it is not response. Okay, what you're looking at is only one wave. We actually record more than one wave to see its replicability and reliability. Okay, so after all those things, we are going to label the waves as P1 and N1. There is a difference in waves depending on where you keep the electrodes. This system which you are using, the neuro audio, it actually changes the polarity, which means polarity of the wave, not the stimulus. Anything that is coming negative, it is inverting it. Okay, but in some cases what happens is the first thing which you're looking at is not the positive peak, rather it will be negative, and then you will have a positive. Even though the peak is coming in the negative side, we are supposed to name it as P1, and even though the peak which is coming in the positive, we will name it as N1. I actually will be showing you that response also. I'm telling you before so that you don't get confused. Okay, and we are reaching 40-minute deadline. So I will close out and we will join back.